Assalamu alaikum. Welcome back to Rukhsana Foundation's YouTube channel. We'll continue from where we left. We'll continue with the anatomy of GI structures. Today we'll be discussing about the biliary structures, the anomalies associated with them, and the formation of various hernias and the structures associated with these. Starting off with biliary structures. Biliary structures are outlines, are the anatomical features that take the bile from the liver and get it down into the duodenum. Bile is formed in the liver, and from there it makes its way from the left and right bile canaliculi and then further join each other to form a common hepatic duct. The other part of the biliary structures is formed by the common bile duct, which is formed when the common hepatic duct combines with the cystic duct. Here you can see this is the gallbladder, this is the neck of gallbladder. From there originates a cystic duct. Cystic duct further combines with the common hepatic duct, and both of them join together to form the common bile duct that makes its way to the second part of the duodenum after joining with the main pancreatic duct. Here you can see an enlargement known as ampulla of Vater that opens around sphincter of Awais in the second part of the duodenum. So bile, it's gonna start flowing from liver, and then it will make its way into the gallbladder, where it will be stored, concentrated, and released whenever there's a need for it, particularly in cases when a person intakes high fat diet. You can easily appreciate how the common hepatic duct and then the common bile duct are very much associated with the main pancreatic duct. Now the pancreas has two ducts. The first one is the accessory pancreatic duct, the second one being the main pancreatic duct. Why this is important is because, let's say if a patient has a stone in the gallbladder, that might make its way through the cystic duct in the area around sphincter of Awais. At this level, it's going to block both the common bile duct and the pancreatic duct. When that happens, both pancreatitis and cholangitis symptoms are going to appear. We might even get cholecystitis as well. Cholangiogram, it's a radiological imaging technique that highlights the various biliary structures. One is ERCP and the second one being MRCP, which we'll discuss further during our discussion about the pathologies. In this image, the resolution of this image is not that good, but it's quite good in the fact that it outlines the left and right intrahepatic bile ducts, which then combine to form a common hepatic duct, and then combined with the cystic duct. This is the gallbladder, and here is the common bile duct combining with the pancreatic duct and opening at the level of sphincter of Awais in the second part of duodenum. There's one more key concept about USMLE Step 1 that is going to be tested. It's about when a tumor originates in the head of pancreas. When that happens, this is the head of pancreas. It's going to press on the opening of common bile duct and pancreatic duct, and when that happens, similarly, which happens in cases of gallstones, pancreatitis and cholangitis can happen. But one key differentiating point is that in cases of carcinoma, mostly the adenocarcinoma, the gallbladder is going to get enlarged but will be non-tender. In cases of gallstones, since we know that cholecystitis might happen, it's gonna make the gallbladder painful. That's why we experience pain in a patient with cholecystitis in the right hypochondrium. But in the cases of adenocarcinoma, the gallbladder will be non-tender, known as the Kawai's sign. So that's a key point highlighting that there might be some malignancy happening in the body of a patient for which we need further studies. Okay, the next parts that we're going to discuss are going to be surrounding around hernias. Hernias are protrusions of peritoneum. through various body structures. Here we're going to discuss the structures related to abdominal wall and the groin area and the interior thigh. This is a good image. Here first you need to appreciate the femoral triangle. Here is the lateral wall of it, or the lateral boundary, which is formed by the sartorius muscle. The upper boundary is formed by the inguinal ligament that makes its origin from anterior superior iliac spine towards the pubic tubercle. The middle boundary of it is formed by the adductor longus muscle. So femoral triangle, it's actually a depression that includes some key structures. From lateral to middle side, we'll have femoral nerve, the femoral artery, and the femoral vein. Along with these, there are going to be present some lymphatics that are going to drain blood, they're going to drain lymph from the lower limb. Other key structure is the femoral sheath. Okay, femoral sheath, it's a fascial tube present between this is the femoral sheath. It's present between below the inguinal ligament, and it contains femoral artery and femoral vein, but not the femoral nerve. So that's a key point that should be kept in mind while solving questions that might test your concept about the anatomical structures of femoral sheath and femoral triangle. Other structures that you can appreciate in this image that are going to be important for our further concepts, one of them is the iliopsoas muscle. So this is psoas and ilias. So iliopsoas is made up of two parts, iliacus and psoas. Iliacus is going to make its origin from the area around here, the ilium bone, and the psoas muscle, it makes its origin from vertebrae, somewhere around the level of kidney, but it's going to be in the middle since it originates from vertebrae. Both of them combine together and then get inserted on femur, somewhere down here around the trochanter's of femur bone. This is also femoral ring. It's different from femoral sheath, but more or less is the same. It's not that high yield in terms of USMLE Step 1. What is high yield is the concept of femoral triangle and femoral sheath. This serves as a surgical landmark during procedures for surgeon, let's say, for surgeons, even for interventional cardiologists. Let's say we want to approach a patient's heart to repair or to replace a particular heart valve. That way we can either use the radial approach, but for procedures like TAVR, which is the replacement of aortic valve, the radial artery diameter might not be big enough. So for allowing the diameter of radial artery might not be big enough to allow the sheath to go through it. So we use femoral approach in those circumstances. There's also a key concept about the femoral hernias. We'll discuss that further, which is also very high yield. The inguinal triangle we're going to discuss moving on forward. Okay, so the next topic is about inguinal canal and the structures related to it. This is the anterolateral abdominal wall layers. These are important in terms of urological procedures, gynecological procedures, and even for general surgeons. Let's say if they want to approach a patient with particular hernia, they might open up the wall around here or here, depending on the pathology's location. Moving forward, posteriorly to anteriorly, we can appreciate this being the parietal peritoneum, and then we have this extraperitoneal tissue, the transversalis fascia, transversus abdominis muscle, internal oblique muscle, and then the aponeurosis of external oblique muscle. Here you can see conjoint tendon that is formed by the combination of aponeurosis of internal oblique muscle and the transversus abdominis muscle. Transversalis fascia, it's going to stay posteriorly further. Now for USMLE Step 1, you need to know about deep inguinal ring and the superficial inguinal ring. Why this is important? Because the hernias, which are the indirect inguinal hernias and direct inguinal hernias, they make their way through this canal or even directly from abdominal wall. Right now here, only you need to understand, the thing that you need to understand is how deep inguinal ring and superficial inguinal ring are related through this inguinal canal. Now normally during embryological development, this canal serves as a descending pathway for testicles in cases of male. In cases of female, this allows the round ligament of uterus to pass through it. For USMLE Step 1, just keep in mind that the deep inguinal ring and the superficial inguinal ring, they are both connected to each other through a canal that's around 4 centimeters long. This is important because this pathway acts as a conduit for protrusion of hernias. This pathway is going to act as a conduit for indirect inguinal hernia, and this one through the anterior abdominal wall, it's going to make a conduit for, not exactly a conduit, but it's going to make as a landmark for protrusion of direct inguinal hernias, which we'll discuss going forward. Okay, about the contents of inguinal canal, I'm going to take help of ChatGPT. The structures are going to be different in males and females. In males, the most important structure is a spermatic cord, which allows passing of vas deferens. Vas deferens is a channel for sperms to make their way from testicle to external urethral meatus. About the arteries and veins, the most important is the testicular artery in terms of arteries. In terms of veins is the pampiniform plexus. Pampiniform plexus enlarges in situations of varicocele. Testicular artery might get lacerated during procedures for inguinal hernias. That's why these are so much important. The other artery is cremasteric artery, and the third artery being the artery to vas deferens. The nerves associated with the inguinal canal are two. The first one is genital branch of genitofemoral nerve, which is actually present inside the spermatic cord. The second important nerve is the ilioinguinal nerve. It is present in the inguinal canal, but it does not make its way from the spermatic cord. That's a key point highlighting that is very much liked by examiners to test. I have talked about the processus vaginalis. Let's say if a patient does not have obliteration of processus vaginalis, this inguinal canal might have processus vaginalis intact with fluid inside its two layers that may allow formation of hernias. It's normally present in newborns, but it gets obliterated as they grow. In terms of females, we do not have vas deferens that we all know. Its homologue, it's going to be round ligament of uterus of the in females. For spermatic cord, there's going to be a round ligament of uterus. And since we discussed that genital branch of genitofemoral nerve is making its way through spermatic cord, this will not be present in terms of females, but ilioinguinal nerve is definitely going to be present. In addition to these nerves, arteries, veins, we're going to have some lymphatics that are going to be present both in males and females that are going to drain lymph from lower limbs and genitals. Okay, that's it for today. Thank you so much for watching our video. Please do like, subscribe, and follow our YouTube channel and press that bell icon. Thank you so much.